Hello friends, welcome to a new topic today. In this chapter, let us now learn about one important topic, which is called as COPD. So, in this COPD, we will learn about what is COPD. COPD mainly contains two different groups of disorders. One which is emphysema, second which is chronic bronchitis. So this picture shows you the obstructive diseases. We have something called as obstructive diseases. These obstructive diseases include asthma, emphysema and COPD. What does obstructive diseases mean? Actually, if you see, the obstructive diseases they mean what does obstructive diseases mean? See, if you see, this is the trachea. We have the airways, right? Bronchi and then bronchioles, like that we have many. Due to some reason, whatever the reason is, there is obstruction of this airway, and because of the obstruction of this airway, distally the air which is filled in the alveoli, it cannot escape, and as a result there is increased air which is left in this alveoli. So this obstruction is there. As a result, it is called as obstructive lung diseases, and these obstructive lung diseases include three, which is emphysema, chronic bronchitis and asthma. Among these three, the most important one is now we are going to deal with this COPD. So what are we going to deal in COPD? See, this COPD, what is COPD? COPD is a condition. Obviously, it is a chronic obstructive pulmonary disease. It is a chronic condition where there is obstruction of lung, airways, leading to disease formation. Remember, see, this is the pathophysiology. How there is obstruction, we will deal with it in a minute. But what happens whenever there is an obstruction? See, think that here, if you see, this is the place where you are seeing obstruction. So whenever there is obstruction, there is, normally what should happen, through the trachea the air should go into the obstructed spaces, and from there the air should go into the oxygen should diffuse into the pulmonary arteries, capillaries, then to the arteries, whereas through pulmonary veins the carbon dioxide should diffuse into the alveoli. This is the ventilation that should happen. But here, whenever there is this obstruction, this ventilation is impaired. So because of the impairment of this ventilation, there is hypoxia, there is decreased because of this loss of ventilation, there is hypoxia, that is decreased oxygen. So whenever there is decreased oxygen, always remember hypoxia stimulates vasoconstriction in pulmonaries. So because of that, there is pulmonary vasoconstriction, which has led to a condition called as pulmonary hypertension. This pulmonary hypertension, actually, if you see, this is the heart. Think that, right atrium, right ventricle, from there the blood goes to the lungs. From there the blood comes back to the left atrium, from there to left ventricle, then it goes to aorta. But here, because there is increased tension in the lungs now, here there is increased tension in the lungs. Because of the increased tension in the lungs, the blood cannot reach the alveoli easily. So there is back pressure. This back pressure also causes back pressure to the right ventricle. So this causes right ventricular hypertrophy. Then now the right ventricle has been increased in hypertrophied. The muscle in the right ventricle has been increased, and later there will be hypertrophy and dilatation of the right atrium also. Because of the hypertrophy and dilatation of right ventricle followed by right atrium, there is tricuspid valve dilatation also, leading to tricuspid regurgitation. Then this will go to the back pressure. And because see there is dilatation of right ventricle, and from there dilatation of right atrium also. Because of the back pressure here, there is increased pressure in the inferior vena cava and superior vena cava. Because of increased pressure in this inferior vena cava, this pressure transmits to the lung, and because of that there is enlargement of lung which is happening here. Because of that there is enlargement of lung which is happening, and there is also, along with enlargement of lung, the back pressure also goes to the feet, leading to pulmonary edema. So this is the main thing that is happening because of this obstruction, right? I think you have understood something about it. Now let us see the risk factors of COPD. What are the risk factors of COPD? Risk factors are COPD are: one, obviously it is due to cigarette smoking, and second, there is airway hyperresponsiveness, and there is mutation of gene called as SERPINA1, which is P1 gene, which codes for alpha-1 antitrypsin. Okay, so if you see what is alpha-1 antitrypsin issue, see, normally in the lungs, okay, in the alveoli, these will secrete alpha-1 antitrypsin. Okay, what does this alpha-1 antitrypsin do? So lungs, there is secretion of elastases also. Whenever there is inflammation, especially in smoking, or whenever there is infections, all these will lead to production of increased elastase and trypsin. Okay, this trypsin, what this trypsin do is, this will break down the alveolar walls, right? Trypsin is a protein, okay, digestive protein. So as a result, it will break down the alveolar walls. So this breakdown of alveolar walls is prevented by the intrinsic enzyme which is present in our body, that is antitrypsin. Antitrypsin is present in our body, and this antitrypsin will prevent the breakdown of this trypsin and thus protects the airway. So if this antitrypsin is deficient, then now the trypsin is free in our body to destruct, and as a result there is destruction of alveoli, leading to chronic obstructive pulmonary disease. Then the second risk factor is occupation. Which occupation? That means fumes, chemicals, or SO2. Okay, exposure of all these will also activate trypsin or elastase, thus causing breakdown of the alveolar membrane. Okay, even the smoking, okay, environmental pollutions, all these are the risk factors. Now once we have learned about the risk factors, you will have to see what is something called as chronic bronchitis. So as I said, there is emphysema and chronic bronchitis. Two things are important. So first we will see chronic bronchitis. So when do you call it as chronic bronchitis? We call something as bronchitis if there is productive cough should be there, and that is productive. Productive is presence of sputum, and that should be there for at least 3 months of consecutive times. 3 months, and this, it should be present for 3 months for at least 2 years. Then we call it as chronic bronchitis. Okay, so this chronic bronchitis also, it is mainly due to smoking. Because of smoking, that smoking will irritate the airway, resulting in, whenever there is irritation of airway, the mucous glands, see, these are the mucous glands, these mucous glands become proliferating, causing mucus hyperplasia occurs. So this mucus hyperplasia, these will secrete mucus. This mucus will obstruct the airways. So because of the mucus which obstructs the airways, it is an obstructive disease. Okay, one thing which you have to see, so what are you going to see in histology? In histology you will see the inflammation. Okay, what do you see in histology? You see one important thing, profuse exudate in the lumen, you will see, and you will see the squamous metaplasia. Normally you will have the respiratory epithelium, which is ciliated columnar epithelium, but in chronic obstructive pulmonary disease there is metaplasia, that is, you see the conversion of normally you have this epithelium, columnar epithelium, and this epithelium gets converted to squamous epithelium, and this is called as squamous metaplasia. This occurs here, and there is also thickened basement membrane is seen here. Okay, you will see one important thing which is called as mucus hyperplasia is seen. What do you see in mucus gland hyperplasia? This is called as Radials Index. Okay, what is Radials Index? See, Radials Index is thickness of this mucus gland. You will take the thickness of this mucus gland thickness, and you will take one more thickness, that is from the cartilage, okay, between the cartilage and the basement membrane. See, the thickness of the mucus glands to the thickness of cartilage from basement membrane is called as Radials Index. So this Radials Index, if this is B, this is A, this is B. A is thickness of mucus glands. So this Radials Index is equal to A by B. What is A? Thickness of the mucus glands. B is thickness of the cartilage. thickness or the distance between the cartilage and the basement membrane. So this is called as Radials Index. Normally this Radials Index is equal to 0.4, but in chronic bronchitis it has been increased. So this is most important thing in chronic bronchitis. Okay, next. Yeah, next if you see, this is also a picture from Robbins. Okay, 1 minute, I'll just clear it up. Yeah, so if you see here, what are you going to see here? See, these are the inflammatory infiltrate, chronic inflammation which you are seeing here. Okay, this is also the chronic inflammation. All this is the chronic inflammation, and this is the bronchitis. So this is chronic bronchitis which you are seeing. Okay, here there are no proper findings, but still there is chronic bronchitis which you can see here with chronic inflammation. Then how does the patient present to you? So if you see this patient, okay, the patient has dyspnea. The patient presents to you with dyspnea, cough, productive cough. The productive cough has copious sputum, and there is history of recurrent infections, recurrent exacerbations and episodes are seen, and there is hypoxia. Obviously I have told that. And one important characteristic feature of this chronic bronchitis is presence of blue blotters. See, what is happening here is there is decreased partial pressure of oxygen. Because of that there is cyanosis, and that there is mild cyanosis, and this mild cyanosis has resulted in this blue blotters. You can see the blue colored lips in this patient, and blue colored, you know, fingers especially. Okay, so this is called as blue blotters. Okay, now then there is one more. This is the picture of chronic bronchitis. Okay, here because of the obstruction, okay, there is obstruction in the airway, right? Because of the obstruction in the airway, the alveoli which have been filled with gas, air, they are not, you know, it is difficult for them to empty, and as a result this alveoli become hyperinflated. So you can see hyperinflated lung margin. See, these lungs are very big. You can even count, if you count the ribs, I'll just count the ribs, you will see that these are hyperinflated. How are you going to see? Just a minute. Okay, so if you see, we'll just count the ribs. Okay, see this, yeah, what is the first rib here? Okay, so this is the first rib, then this is the second, third, fourth, fifth, sixth, okay, seventh, eighth. Okay, I think I've counted it wrong. 1 minute, I'll count it again. Sorry, this is the first, second, third, fourth, fifth, sixth, seventh and eighth. Normally there will be only 6 ribs till diaphragm, but here we are having 8 ribs from the diaphragm which are seen. So this is hyperinflated lung field. Okay, so this is called as hyperinflated lung field, overinflation. Okay, and you can even see the thick bronchovascular margins which you can see. Okay, this X-ray is important. Next, so we have learned about the chronic obstructive pulmonary disease. This is just the same thing. Okay, the risk factors are cigarette smoking and airway responsiveness, and it is also important which is mutation of gene SERPINA1 which codes for alpha-1 antitrypsin. Okay, and here the alpha-1 antitrypsin, this I did not tell you. See, in the alpha-1 antitrypsin we have the levels of alpha-1 antitrypsin which is common. If the levels of alpha-1 antitrypsin are normal, then we call it as M allele. If they are slightly decreased, then we call it as S allele. If they are markedly decreased, then we call it as Z allele. If there is no alpha-1 antitrypsin levels, then we call it as null allele. So which is most severe among these? Null allele is most severe among all these. Okay, but if there is one null allele and one Z allele, even this is most severe. Okay, then occupation, combination of smoking and asthma and environmental pollution, all these are the risk factors. Okay, so as I have said, the proteases from RBCs, they will actually do connective tissue digestion, but this connective tissue digestion by these proteases is inhibited by alpha-1 antitrypsin. If this alpha-1 antitrypsin is deficient, these proteases can easily digest the connective tissue, thus resulting in airway damage. Okay, this is important. What are the different deficiencies when is there alpha-1 antitrypsin deficiency? Alpha-1 antitrypsin deficiency is seen in bronchiectasis, hepatic cirrhosis, and vasculitis, paniculitis. Okay, these are the different conditions where you see alpha-1 antitrypsin deficiency: bronchiectasis, hepatic cirrhosis, vasculitis, and paniculitis also. Okay, so I have said about chronic bronchitis. Chronic bronchitis is productive cough for at least 3 months in at least 2 years, consecutive years, in the absence of any cause. Smoking is one of the causative factor which causes mucus hypersecretion. And histology, in this I have said there is Radials Index is very important, right? This Radials Index is thickness of mucus gland to the cartilage and epithelial basement membrane, right? And then the clinical features I have said, among all these the most important is blue blotters, and I have already explained you about the core pulmonal pathway, right, which occurs. So this is the complication which is core pulmonal. Okay, so this is chronic bronchitis. Then after chronic bronchitis, the next one which is important here is about emphysema, right? So what do you know about emphysema? See, here in emphysema there is permanent abnormal enlargement of air spaces. If you see, there is permanent abnormal enlargement of air spaces. This air spaces enlargement can occur, which any type of air spaces can undergo enlargement. So what is the etiological feature? Obviously there are two etiological features which are most important. One being smoking, which is most important. Second is alpha-1 antitrypsin is most important. Okay, now see anatomical distribution of this emphysema. Emphysema is divided into mainly two different types. One, we have, this is the normal lung acinus. So if you see, we have in the normal lung acinus we have the terminal bronchiole. Okay, this is the septum. We have respiratory bronchioles, which are 3 orders, and we have alveolar duct and alveolar sac. This is alveolar duct and alveolar sacs. Now in Acinar emphysema, if you see, there is dilatation of central part. What is actually dilated? Central part matlab there is dilatation of respiratory bronchioles. These are the respiratory bronchioles, right? This part is the respiratory bronchioles. So there is only distension of respiratory bronchioles of all the types. Then we call it as Acinar emphysema. So let us see some important points about Acinar emphysema here itself. So this Acinar, see, it's easy to remember. Say S, sa. So this is smokers. This is most common in smokers. Okay, it is most common in upper lobe. If you see in the lung, it is most common in upper lobe, and it is the most common type seen. Okay, that is Acinar emphysema. So if you see here, all the airways are inflamed. Okay, not just the central part, but all, from the terminal bronchiole to the respiratory bronchioles, alveolar ducts, alveolar sacs. So all parts of the acinar are involved. So that is called as pan-acinar emphysema. Okay, in this pan-acinar emphysema, if you see, it is most commonly seen in alpha-1 antitrypsin deficiency. We have learnt about alpha-1 antitrypsin deficiency. It is found in this, and it is most common in the lower lobe of the lung. Okay, now we have two more types also, which are called as distal acinar emphysema, and there is one more called as irregular emphysema. Okay, in distal acinar or paraceptal emphysema, actually the distal part, see, we have seen this is the proximal part, this is the pan-acinar part. Now only the distal part is affected. So all this is normal actually. Okay, in this part, all this part is normal, and only the distal part is affected. Okay, distal part is affected, and these respiratory bronchioles here are normal. Okay, what do we call this as? This is called as paraceptal, or this is seen, this is distal part. So this is called as paraceptal or distal acinar emphysema. Okay, this is called as paraceptal or distal acinar emphysema. And there is one more type of emphysema, which is irregular emphysema, where obviously there are irregular acini which are seen. So we have 4 types of emphysema, which include centri-acinar emphysema, pan-acinar emphysema, distal acinar or paraceptal emphysema, and irregular emphysema. So if you see the clinical features, as I have already said, smoking is the main risk factor. This smoking will generate the free radicals, and also they will cause inactivation of antiproteases like alpha-1 antitrypsin. So because of the deficiency of alpha-1 antitrypsin, there is increased neutrophil elastase. This will cause tissue damage. So because of tissue damage, the alveolar integrity is lost, leading to distension or dilatation of alveoli. So how is the patient seen here? Here also the patient will have dyspnea, cough there will be there with scanty sputum. There won't be that copious sputum as that which you see in chronic bronchitis. And here the patient will have weight loss. Okay, and he will have something called as pursed breathing. He will do pursed action. This is pursed lip. So he does pursed breathing. Okay, and these patients are called as pink puffers. Okay, and there is pursed lip breathing. So these are the important things which you see. Then if you see the cross section, so this is which type of emphysema? See, if you actually see properly, here only the central part of the acinus is involved, and here it is mostly upper lobe is involved. So it is centri-acinar emphysema. Okay, so this is upper lobe involved. Okay, so if you see here, the whole alveoli acinus is involved. The whole of the lung parenchyma is involved, and it is present both in upper lobe and lower lobe also. So this is pan-acinar emphysema. Okay, then this is the same history, you know, the same pathogenesis. Just take a look at it. Even here there is activation of the all inflammatory mediators, leading to damage of alveoli. Then if you see these are the acini. So these are the pictures from Robbins. These are the acini which you see. See, these are the acini which are dilated. Okay, distended alveoli are these. Okay, so these are mainly the centri-acinar, and these are in the central part itself. So these are centri-acinar emphysema. And if you see, there are some pigments here. See, black colored pigment. What are these called? These black colored pigments are called as anthracortic pigments. Okay, because this is mainly because of coal. Well, it is because of deposition of smoke and pollution. Okay, this is the similar X-ray where you see hyper inflated lung. Okay, there is one more thing. There is diaphragmatic flattening is also seen. There is flattening of diaphragm. See, diaphragmatic flattening is seen. Where is it? Yeah, flattening of diaphragmatic leaves is seen here. Okay, so this is this is emphysema. Okay, if you see, this is the CT picture which shows pulmonary emphysema. See the lung spaces. See the lung spaces here. How are they? They are distended. Okay, so this represents the which is highly distended lung margin. So this is centri-acinar emphysema. Okay, this is one more picture of chest showing. This is the pan-acinar emphysema, and this is the radiograph. See the hyper inflated field. If you count the rib margins, there will be more than 6. Okay, then this is the picture of a person who has both emphysema and chronic bronchitis. See, in our clinical field, we generally do not see the isolated emphysema or isolated chronic bronchitis patients. Most commonly, we see the combined pictures of the both emphysema and chronic bronchitis patients are mostly seen, who have both the features rather than one. Okay, then the same pictures, but some more. So if you see, this is the picture which is showing distal acinar emphysema. See, they are present in the pleural areas. See, this distal acinar emphysema, one important clinical picture is these are seen in the pleural, at the pleural ends. adjacent to pleura. So these are seen in the subpleural areas of upper lobe and the posterior aspect of lower lobe. Most commonly they are seen in the subpleural areas, and as a result, see in the pleural areas you see these emphysema which are distal acinar or paraceptal emphysema. Okay, so these are the pulmonary emphysema. See the dilated air spaces, see how large the alveoli are. Okay, so this is again interstitial emphysema, which you see, where you see bubbles of gas with also subcutaneous tissue. Okay, here you see bubbles of gas with subcutaneous adipose tissue. Okay, this is the skeletal muscle which is seen on the top. Here you see that skeletal muscle. Okay, so this is interstitial emphysema. Then what do you see here? So what is interstitial emphysema? Once more, I didn't tell that, right? Interstitial emphysema is not present in lung. Remember, it is not in lung. Okay, it is in subcutaneous fat. Some regions, any region where there is fat, it is present. Okay, it should not be shown here, but because emphysema word has come, I just thought of showing you pictures. See here, you can clearly see where is the emphysema, where is the gas collection. There, the collection of the gas or dilated air spaces are present in the wall of the chest wall, not in the lungs. The lungs are clearly normal. See, these are normal lungs, right? So here, this is the interstitial. This is called as interstitial emphysema. Okay, next. Okay, let us see just the same things. So emphysema is abnormal dilatation of hair spaces, that is acinus. So we have the 4 types of emphysema, which is centri-acinar, pan-acinar, distal acinar or paraceptal, and irregular. You can go through these. Okay, clinical features are you have increased dyspnea, weight loss, late onset of cough and scanty sputum. Okay, signs are also present. See, these signs I'll explain in one clinical class. Then one important thing is the most common complication of this emphysema is again cor pulmonale, and this table is very, very important. Okay, we will just go through this. Okay, chronic bronchitis and emphysema. What is the difference between chronic bronchitis and emphysema? So if you see, chronic bronchitis is most common in the age group of 40 to 45 years, whereas emphysema, it is present in a little older age group, that is 50 to 75%. The most common clinical feature of chronic bronchitis is, if you see, the most common histological feature or characteristic histological feature of chronic bronchitis is mucous gland hyperplasia, squamous metaplasia. So these are peculiar, right? So because there is mucous gland hyperplasia, clinically you see increased expectoration, and because of increased mucus production, that will provocate cough. So most common clinical feature is cough with expectoration in chronic bronchitis. In emphysema, if you see, you do not have much cough because the air spaces are dilated. Even though there is mucus production, that will not irritate the airway. Here the main problem is in the the gas exchange. The gas exchange is not happening properly, and that is the reason why there is increased dyspnea, which you see in this emphysema. Okay, then in both these conditions, where is infection most common? Infection is most common in chronic bronchitis. Why is infection most common in chronic bronchitis? See, if you remember what occurs in chronic bronchitis, there occurs the metaplasia, that is the epithelium, columnar epithelium gets converted to squamous epithelium, right? So because the columnar epithelium is getting converted to squamous epithelium, there is no in the columnar epithelium we have cilia. In lung we have ciliated columnar epithelium. So because it gets converted to squamous epithelium, there is loss of cilia. So as a result, all the bacteria, viruses which are filtered by the cilia, that action is lost, and as a result there is increased chances of infection. And then in the chronic bronchitis or emphysema, where is respiratory insufficiency faster? See, respiratory insufficiency is faster in chronic bronchitis. Why? Because there is mucus production, there is obstruction of bronchiole, right? And as a result, there is difficulty for him to inspirate and expirate. So there is repeated respiratory insufficiency. There will be episodes. Whereas in emphysema, the respiratory insufficiency increases only in the terminal stages. See, in chronic bronchitis and emphysema, where is cor pulmonale most common? See, in chronic bronchitis and emphysema, in both you see cor pulmonale in some patients. But Where is it more common? It is more common in chronic bronchitis. As I have already said, because of the obstruction, I have told you the pathophysiology also, if you remember. So chronic bronchitis, core pulmonal is most severe in chronic bronchitis. So in chronic bronchitis and emphysema, where is airway resistant high? It is high in chronic bronchitis. Why? Because of airway obstruction, right? In chronic bronchitis, the main problem is obstruction of airway because of mucus secretion. Whereas in emphysema, the problem is dilatation of airway because of this, antitrypsin and everything which is being secreted, right? So here airway resistance is normal. Then what are you going to see more? Elastic recoil. In chronic bronchitis, elastic recoil is normal, okay, because the alveoli is not much destroyed. The alveoli are almost normal. The only destruction is increased. Actually, its thickness is increased. The alveolar wall thickness is also increased in chronic bronchitis. So elastic recoil is a little normal. But here in emphysema, the elastic recoil is decreased because the alveoli is thinned out and it is distended. So there is no chance for elastic recoiling. So as a result, it has been increased. Okay, and then on chest x-ray, what are you going to see? On chest x-ray, you see increased bronchoalveolar margins in chronic bronchitis. I have already shown you this x-ray, right? Let me show you again. See, here you see increased bronchoalveolar margins, if you see, in chronic bronchitis, right? In emphysema, what are you actually seeing? There won't be much increased bronchoalveolar margins, but there will be increased hyperinflation will be there. Hyperinflation will also be there in chronic bronchitis, but it is not as much as this emphysema. See, the bronchoalveolar margins are not that marked in emphysema, right? See, in our clinical practice, mostly we see the cases which have a combination. We don't see isolated cases most commonly. Okay. So, in chronic bronchitis, they are blue blotters. I have already told them. And in emphysema, they are pink puffers. Then, in chronic bronchitis, there will be decreased oxygen, so causing central cyanosis. And there is increased partial pressure of carbon dioxide in chronic bronchitis. In emphysema, you have decreased oxygen and decreased partial pressure of carbon dioxide. See, in chronic bronchitis, because there is decreased partial pressure of oxygen and increased partial pressure of carbon dioxide, this is called as type 2 respiratory failure. Whereas in emphysema, we have type 1 respiratory failure. Okay. Then in chronic bronchitis, we have respiratory acidosis. These are very important. Okay. In emphysema, we have respiratory alkalosis. Okay. How are you going to treat it? Treatment of chronic bronchitis is mainly you'll have to give antibiotics and you will have to give mucolytics. If there is pure emphysema and if it is confined to one lobe, you can do video assisted thoracoscopic surgery. Then what is the treatment of choice? Treatment of choice of chronic bronchitis is low flow oxygen, whereas emphysema, treatment of choice, if you were asked, that is lung transplantation. So these are the differences between chronic bronchitis and emphysema. Now, once we have learned about the differences between chronic bronchitis and emphysema, now we will have to go to the laboratory function test. Okay. In the laboratory functions, one important thing is pulmonary function test. So this is the pulmonary function test or automated spirometry testing, which you are seeing in the figure. So here, if you see, what is this person doing? She has this tube and she is blowing into this tube, and you will have this automated spirometry reading. So what are you going to see in this spirometry? See, in this spirometry, this is how the spirometry looks. See, in this, what actually the spirometry measures is fractional this spirometry actually measures forced expiratory volume 1. What is this forced expiratory volume? Forced expiratory volume in 1 second. Okay, that is FEV1. It also measures FVC, that is forced vital capacity, functional expiratory volume in 1 second, and forced vital capacities. right? So FEV1 is seen. See, this is the time, 1 second. In 1 second, with how much force is she actually exhaling the air? So that is what we see in FEV1. Okay, normally how does, before we go into this graph, I'll just draw you the FEV1 graph, how normally we see this. See, normally if you see, this is the graph. Okay, this is the expired air which you see, and this is the times taken. It will be a peak. First it will increase. As you increase, you will have to forced expiratory volume. So you'll have to ask the person to forcefully blow out the air. So as a result, when he forcefully blows out the air, within 1 second, almost all the air is blown out. But in COPD, if you see, this occurs slowly. This rise in peak occurs very slowly. Okay, you can see this in this picture. See, the rise in peak of this normal person is given in black color, if you see. So this is how the normal person exhales. It like in one blow he can exhale most of the air. Within 1 second he can expire all the air. But here in COPD he finds it difficult to expire the air. So because of this, there is decreased FEV1. Okay, then what else if you see? Then there is one more thing. If you see, the flow is, see, this is decreased, right? The flow is also decreased. Okay, so in obstruction he is not able to expire the air, right? So here the FEV1 is decreased. That is, the amount of air that he exhales in 1 second is actually decreased. See, he should exhale this amount of air normally, but he is exhaling only this much. So this part, where is it? There it is present in the lungs itself. Okay, so the lungs, the air which is left in the lungs is increased. So what is that air which is left in the lungs? That is nothing but residual volume. So because of this, here if you see, the residual volume has been increased in this situation. Okay, so I'll write it here. Okay, so because of this, see, normally he should exhale this amount of air. This is in normal person. But in COPD, what is happening is, he is not exhaling, he is just exhaling this amount of air. So this part, this amount of air which is left, this amount of air which is not exhaling, this is stored in the lung, again has residual volume. So there is increased residual volume. There is decreased functional FEV1, there is decreased FEV1 and there is increased residual volume. Because of increased residual volume, there is increased total lung capacity. Okay, so that is what you are seeing in this graph. In this graph, if you see here, this is the normal value, total lung capacity. Here total lung capacity is increased. Why? Because the residual volume is increased. And if you see closely, this expiratory reserve volume is almost similar. Okay, anyways, this residual volume is the one which is mostly increased, and as a result total lung capacity is increased. Okay, next. Right, so we will see this picture. So this is how the emphysema patients look. So this is called as pursed lips. See the way that he put his lips like this. He's exerting pressure through the oral cavity in order to exhale. Okay, so that is called as pursed lip. Okay, slowly he is exhaling. Okay, so what are you going to see here? See, this is the normal. Normally this is the inspiratory capacity, inspiratory reserve volume. This is the normal spirometer which you see. But here this is the residual volume, right? This part. But here what is increased? Residual volume is increased. Because residual volume is increased, the total lung capacity is also increased. Okay, so that is one thing which you have to keep in mind. This one, what is this? This is elastic recoil pressure. Okay, this elastic recoil pressure, this is against elastic recoil pressure against TLC has been plotted. And here what are you going to see? Here emphysema, the recoil pressure has been increased. Okay, actually the TLC has been increased, not the elastic recoil pressure. TLC has been increased, total lung capacity has been increased in this patient. Okay, so this is about the investigations. So let us go into the notes. See, this is the same thing, and there are some signs also which I have told in this. See, this is the Hoover sign. See, what are you going to see in the Hoover sign? In the Hoover sign, this is paradoxical inward movement of rib cage during inspiration. Okay, so that is called as Hoover sign. Then I have already said in pulmonary function test, there is decreased FEV1, there is decreased FEV1 by FVC ratio, there is increased total lung capacity, and there is increased functional residual volume, and there is increased residual volume. Okay, arterial blood gas analysis in emphysema, there is decreased PO2 and decreased PCO2 is seen. Okay, X-ray I have showed many X-rays to you, right? CT scan also have shown. This presence of emphysematous bulla is the definitive test in CT scan. Okay, then 2D echo is just to assess, because there is a complication of core pulmonal, so that is to assess the core pulmonal. Now staging of COPD. COPD is staged by Global Obstructive Lung Classification, which is GOLD classification. This is very important. Okay, okay, this is very important, this GOLD classification. In this GOLD classification, we have this stage, okay, FEV1 and FEV1 by FVC ratio. Okay, then at stage 0, FEV1 is more than 80% and FEV1 by FVC ratio is more than 0.7, that is normal. In stage 1, mild, which is called as mild, where FEV1 is more than 8 and FEV1 by FVC ratio is more than 0.7. Sorry, less than 0.7. Remember, in stage 0, FEV1 by FVC is more than 7. In stage 1, 2, 3, 4, FEV1 by FVC ratio is less than 0.7. So, it's simple. You will have to just remember the FEV1. This FEV1 is the one which determines this stage. Okay. So, if it is 1, then it is mild. Then the FEV1 ratio is more than 80. If it is moderate, FEV1 ratio is more than is around 50 to 80. If it is severe, FEV1 ratio is 30 to 50. If it is very severe, FEV1 ratio is less than 30. So, how are you going to treat it? So, this global classification, lung disease classification, this is very, very important. Don't forget to read this and go to the exam. Okay. Then we have this treatment. See, the treatment is almost simple. You will have to do smoking cessation, where first, because the causative factor here is smoking, so you will have to advise the patient to stop smoking. Okay, first and foremost thing is you will have to ask the patient to stop smoking, and then you should give the bronchodilators. Okay, in the bronchodilators, you can give anticholinergic agents like ipratropium bromide and tiotropium bromide, or you can give beta agonists like salmeterol or salbutamol. Okay, then you can also give inhaled glucocorticoids like beclomethasone or fluticasone or budesonide. You can also give oral glucocorticoids. All these depends upon the stage. Okay, all these depends upon the severity. If there is more severe, then you will have to put him on oral glucocorticoids. You can give theophylline also, or doxophylline, which are prostaglandin E2 analogs. The clear about all these we have learned in pharmacology. Okay, then we have an index called as Board index. This is also very important. You should not forget reading this. This Board index is B for BMI, O for obstructive lung disease, D for dyspnea, and E for poor exercise tolerance. B for BMI, O for severe obstructive disease, D for severe dyspnea, and P for exercise intolerance. This is important. If there is alpha-1 antitrypsin deficiency, then always consider heart-lung transplantation, or you will have to give IV alpha-1 antitrypsin from cold human plasma, because you can, even if you give any of these, all these are symptomatic therapy. The main problem is in alpha-1 antitrypsin, then you will have to treat that. So, when do you do lung transplantation? What are the recommendations for lung transplantation? If the age of the child is if the age of the patient is less than 65 years, or if there is severe disability despite of medical therapy also, if he had severe disability, or if he is free of comorbidities like liver, renal and cardiac disease, then you can do this lung transplantation. Then the complications. See, in the complications, this is complications of emphysema and complications of chronic bronchitis. Okay, most of them I have already told you. See, in emphysema there is dilatation. I'll even tell you now. In emphysema, what is happening is there is dilatation of air spaces, and as a result these thin air spaces will rupture, okay, and they form the bulla, okay, and these ruptured bulla can result in spontaneous pneumothorax. This is the pleura, and this can result in spontaneous pneumothorax. Okay, there can be respiratory failure. Definitely, I have told you there will be pulmonary hypertension and heart failure also. Then chronic bronchitis. In chronic bronchitis, there will be carbon dioxide narcosis. Initially, there will be type 1 respiratory failure. Later, it converts to type 2 respiratory failure. Obviously, here in chronic bronchitis, there is decreased oxygen. Because of that, this will activate the erythropoietin. Okay, this decreased erythropoietin increases RBC, causing polycythemia. It also causes cor pulmonale. I have already told you about the features, how it results in cor pulmonale. Okay, so the last thing is about exacerbation. See, the causes of COPD exacerbation can be anything. It can be infection or non-infectious. If it is infectious, it is most commonly viral infection, or it can be bacterial infection. Any virus or bacteria can result in it. And if it is non-infectious, most commonly it is air pollution. So what is the strongest predictor of future exacerbation? History of prior exacerbation. If a person has one history of exacerbation, then there is increased chances that he lands up with future exacerbations. So in this treatment, what should you give for this patient? You should give bronchodilators, oxygen therapy. First and foremost is oxygen, followed by bronchodilators. Then if there is any infectious signs, you will have to put him on antibiotics, and glucocorticoids should be given. Even after giving all these also, if the partial pressure of oxygen is not maintaining properly, then you will have to put him on mechanical ventilation. In the mechanical ventilation, the most important is to start him on non-invasive ventilation. If still even on non-invasive ventilation he is not able to cope up with it, then you will have to shift him with invasive ventilation. See, this COPD and emphysema, chronic bronchitis, these patients, they will slowly deteriorate by the end of the age. Okay, as age progresses, the number of attacks increases and increases, and they start deteriorating, and they land up in heart failure, pedal edema, all the heart issues will arise, and they land up in cor pulmonale. Okay, so this is about the chronic obstructive pulmonary disease. Thank you guys for watching my lecture. Thank you.